Hello group. Well, as you know, I'm going to speak about the preconception care. I'm going to give you an introduction, some of the nice recommendations and advice that should be given to women with diabetes who are planning to become pregnant. This will include diet, monitoring of blood glucose, retinal and renal assessment in the preconception period, basically. Approximately 87.5% of pregnancies complicated by diabetes are estimated to be due to gestational diabetes, with 7.5% being due to type 1 diabetes and the remaining 5% being due to type 2 diabetes. As we all know, diabetes in pregnancy is associated with risk to the woman and to the developing fetus. Miscarriage, preeclampsia, and preterm labor are more common in women with pre-existing diabetes. In addition, diabetic retinopathy can worsen rapidly during pregnancy. Stillbirth, congenital malformations, macrosomia, birth injury, perinatal mortality, and postnatal adaptations problems are more common in babies born to women with pre-existing diabetes. The level of risk for women with type 1 or type 2 diabetes and for the baby is largely determined by the health of the woman just before conception and within the first 11 weeks of pregnancy. This is the main reason that explains why the preconception care is so important with women with diabetes, especially diabetes type 1. Women with diabetes who are planning to become pregnant should be offered information about how diabetes affects pregnancy and how pregnancy affects diabetes. According to NICE guidelines, the information they receive should cover the role of diet, body weight and exercise, the risk of hypoglycemia during pregnancy, how nausea and vomiting in pregnancy can affect glycemic control, the increased risk of having a baby who is large for gestational age, which increases the likelihood of birth trauma, induction of labor, and cesarean section. The need for assessment of diabetic retinopathy and diabetic nephropathy before pregnancy. The importance of maternal glycemic control during labor and birth and early feeding of the baby in order to reduce the risk of neonatal hypoglycemia. And finally, the possibility of transient morbidity in the baby during the neonatal period, which may require admission to the neonatal unit. Also, women with diabetes who are planning to become pregnant should be advised that additional time and effort is required to manage diabetes during pregnancy, and that there will be frequent contact with healthcare professionals. Women should be given information about the local arrangements for support, including emergency contact numbers. They should also know that the risk associated with pregnancies complicated by diabetes increase with the duration of diabetes. They should be recommended to use contraception until good glycemic control has been established. Glycemic charges, glucose monitoring, medications for diabetes, including insulin, and medication for complication of diabetes, will need to be reviewed before and during pregnancy. I wanted now to show you a video about the top preconception tips from a woman suffering from diabetes. This is included in the Diabetes UK website and I found it really useful.
Hi there, Becca here. You found the story on the web. I hope you found it interesting. And now you know that women with diabetes have to plan their pregnancies before they even start trying to conceive. So let's get down to the nitty-gritty. Here are my preconception tips. Don't stop using contraception until you're ready to have a baby. Plan your pregnancy. Involve your diabetes care team. Let them know as soon as you start planning to get pregnant. You're more likely to have a safe pregnancy and a healthy baby. They are on your side. I know it's challenging. Try and keep your blood glucose levels to the target. Try not to let it have massive swings one way or the other before and after conception. Folic acid. Now you need to take 5 milligrams of this every day from when you start trying to conceive until you're 12 weeks pregnant. If you're on statins or ACE inhibitors, you need to stop taking them before you start trying to conceive. They could damage the baby if you are still taking them when you do conceive. And if you're on any other medication, check with your care team before trying to get pregnant. Although I have type 1 diabetes, these preconception tips also apply to those with type 2. I know it might sound daunting and the risks are serious, but don't stick your head in the sand, cross your fingers and hope for the best. Take control. Having a baby is one of the most important decisions you'll ever make. Be prepared. I know I keep banging on about this, but involve your diabetes care team. You're much more likely to have a healthy pregnancy and baby. I wish you all the very best, and I hope your pregnancy story ends just as happy as mine did.
It's good, isn't it? Well, I'm going to speak about the when and how to offer information. Women should be informed about the benefits of preconception glycemic control at each contact with healthcare professionals, including midwives, and their diabetes care team from adolescents. The intention of women with diabetes regarding pregnancy and contraceptive use should be documented at each contact with their diabetes care team. Preconception care for women with diabetes should be given in a supportive environment, and the woman's partner or other family members should be encouraged to attend. Now we are going to see what advice we will give women with diabetes related to diet, dietary supplements, body weight, and exercise. Women with diabetes who are planning to become pregnant should be offered individualized dietary advice. Women who have a body mass index above 27 should be offered advice on how to lose weight. Women should be advised to take folic acid 5 mg a day until 12 weeks of gestation to reduce the risk of having a baby with neural tube defect. We've seen that a good glycemic control is really important during the preconception care. Regarding the target ranges for blood glucose in the preconception care, it's important to keep in mind that individualized targets for self-monitoring of blood glucose should be agreed, always taking into account the risk of hypoglycemia. If it's safely achievable, women should aim to maintain their HbA1c below 6.1%. They should be reassured that any reduction in HbA1c towards the target of 6.1% is likely to reduce the risk of congenital malformations. Women with diabetes whose HbA1c is above 10% should be strongly advised to avoid pregnancy. There is additional information to take into account in the preconception period regarding monitoring of blood glucose and ketones. Women should be offered monthly measurements of HbA1c. They should also be offered a meter for self-monitoring of blood glucose if they don't already have one. Those of them who require intensification of hypoglycemic therapy should be advised to increase the frequency of self-monitoring of blood glucose to include fasting and a mixture of pre- and postprandial levels. Women with type 1 diabetes who are planning to become pregnant should be offered ketone testing strips and advised to test for ketonuria and ketonemia if they become hyperglycemic or unwell. Most of the time, to maintain a good glycemic control, it's necessary to introduce or change some kind of medications. In this case, it's important to know about the safety of these medications for diabetes before and during pregnancy, in order to reduce the harmful effects that they could have on mother and baby. Women with diabetes may be advised to use metformin as an adjunct or alternative to insulin in the preconception period and during pregnancy, when the likely benefits from improved glycemic control outweigh the potential for harm. All other oral hypoglycemic agents should be discontinued before pregnancy and insulin substituted. For women with insulin-treated diabetes, isoften insulin, also known as NPH insulin, remains the first choice for long-acting insulin during pregnancy. Statins, for example, atorvastatin, should be discontinued before pregnancy or as soon as pregnancy is confirmed. As we know, diabetes can have an impact on the vision and kidney function. It's important to know then that in the preconception period, there should be an assessment of both. Women with diabetes seeking preconception care should be offered retinal assessment at their first appointment, unless an annual retinal assessment has occurred within the previous 6 months, and annually thereafter if no diabetes retinopathy is found. Women with diabetes should be offered a renal assessment, including a measure of microalbuminuria before discontinuing contraception. If serum creatinine is abnormal or the estimated glomerular filtration rate is low, referral to a nephrologist should be considered before discontinuing contraception. Well, to briefly summarize what we've seen so far, I've written down the main points I think we need to consider when visiting diabetic mothers who wish to become pregnant. First of all, we need to know the importance of the preconception care. Work in a multidisciplinary team. The role of the contraception until a good glycemic control has been established. Folic acid recommendations, optimal glycemic control, diet, and glucose monitoring. However, I wanted to talk to you about the confidential inquiry into maternal and child health survey of maternity services in 2010. This showed that only 70% of maternity units in England, Wales, and Northern Ireland provided structured multidisciplinary preconception care for women with diabetes. In this survey, less than half were recorded to take folic acid supplements prior to pregnancy. Less than half were recorded to have had preconception counseling regarding glycemic control, diet, contraception, diabetic complication, and alcohol intake. Just a third were recorded to have a test of glycemic control in the 6 months before pregnancy, and 2/3 had evidence of suboptimal glycemic control before conception and in the first trimester of pregnancy. All of this, that is, suboptimal preconception care, glycemic control before and during pregnancy, and approach of the woman to managing her diabetes, were all associated with poor pregnancy outcomes. This survey can help us to know how to improve maternity services in the future. For this purpose, we need to know the reasons why it didn't work well. One of the main underlying factors to suboptimal preconception care was failure of provision of appropriate care by health professionals. Preconception counseling, contraceptive advice, provision of high-dose folic acid, and appropriate screening and management of diabetes complications. The main factors underlying suboptimal glycemic controls and a suboptimal approach to managing diabetes were social and lifestyle issues. For example, non-attendance of women at planned appointments, unplanned pregnancy, and social factors including language difficulties, difficult domestic circumstances, and busy lifestyles. Only a minority of women in the inquiry appeared to be using any form of contraception in the 12 months before pregnancy. This suggests that women are not aware of the importance of continuing effective contraception until their glycemic control is as near normal as possible. Furthermore, there was poor documentation of preconception care and advice given. Finally, then, we could conclude that preconception care for women suffering from any kind of diabetes need to be improved. As we all have seen in placement, preconception care tends to be overlooked sometimes, but most of the times could avoid future complications we are facing in practice. Regarding diabetes, benefits of enjoying an optimal health before getting pregnant are many, and our objective as midwives is to pass this information and make it understandable and easy to apply in women's day-to-day life, taking into account the psychological aspect of this condition, which could imply concern, anxiety, and fear. And that's everything. I hope you've enjoyed this presentation. Thank you very much for your attention. Bye!